אוקיי, שלום לכולם, צהריים טובים. אני מאוד שמחה על ההזדמנות לקיים סמינר משותף נוסף בסדרת הסמינרים של מכון חרוב ומכון ברוקדייל. אמנם אני יושבת בביתי בבית ספר לעבודה סוציאלית באוניברסיטה העברית, אבל אני כאן בכובעי כמנהלת המחקר והערכה של מכון חרוב, וזו הסיבה שיש פה גם מגוון של אנשים שלא טיפוסי בדרך כלל לסמינרים של בית הספר שלנו. אני מאוד מאוד שמחה על ההזדמנות לארח את פרופסור גוטרמן, שהוא דיקן בית הספר לעבודה סוציאלית באוניברסיטת שיקאגו, ואחד מהמומחים הגדולים שיש בתחום של רווחת הילד וטיפול בילדים שחוו התעללות והזנחה בפרט.
Okay, great. Well, I should say I'm really honored and excited to be here. It feels like when Yona came to accept an award from my school a few months back, he said it was a little bit like a homecoming because he had spent some of his formative years in my school, and for me it's like coming to Hartzell in some ways is like a homecoming too, because I did a postdoctoral fellowship and met Muhammad and many friends here, and I met my wife here just down the street recently, not recently, but when it feels recently, it feels like it was yesterday. But so this is very much like a homecoming, so it's really a great pleasure and honor to be able to speak to you. My own scholarship, just in general, has focused on the area of children and victimization in a broad sense. And I have focused most of my research in the last decade and a half on the early prevention of child abuse and neglect. Muhammad and I also have done some ongoing work on kids' exposure to violence outside the home here and also back in the States too, in the Palestinian Authority. So what I've interacted with Anat and Ashif and Aryeh, I'm very grateful that they
He will join us shortly.
Well, I'm grateful that they invited me to join. We had some back and forth about what would be most of interest, and the general topic of fathers is something that I think is maybe on the newer edge of things, both in the States and perhaps here. I want to talk about that topic in the context of the early prevention of child abuse and neglect. That's sort of my window in, or my roadway into the concern and consideration of fathers, and I'll tell you why shortly. So what I'd like to do is, in the next, I guess, hour and a half or so, we'll have some, obviously, time for questions and answers. If you have questions in the middle, please feel free. I'll try to make sure we have time for all the content. What I want to do, first and foremost, is overview the American context around the problem of child abuse and neglect. In America, child maltreatment is the gateway to the child welfare system. And there's been some very interesting and rather rapid developments, I think very hopeful developments, with regard to prevention of maltreatment before the fact, before it ever occurs. So actually my own background as a clinician, as a practicing social worker, was in what we in the States call the deep end of child welfare. That is when kids were, after they come into the child welfare system because of maltreatment, and the journey through the child welfare system, as they were going out the back end into adoptions or back home sometimes. So much of my own work was working with children who had been in institutional settings because of severe abuse and neglect. That's sort of where I got my start. And I remember very well thinking at the time, you know, why didn't someone help this kid and this family long before the tragedy happened, long before the problems were so deeply entrenched, long before the state had to come in coercively and in a very expensive way, in a way that has very little chance of making a difference. So much of what my work then, since then, has been is from the front end of the child welfare system, actually even before the child welfare system, even before families come to the attention of the before families get to the point where there's some problem. So what I want to do is I want to overview for you what's been going on in the States around that, at that point, at that very early end, in early prevention, use that as a stage setting context for talking about fathers. Because in the States, and maybe here as well, fathers have, for the most part, been sort of out of the equation, out of the picture on the service front. So we'll talk about that from an early prevention standpoint. And then as time allows, then I'll talk with you a bit about a intervention study that we've been doing, where we actually have designed, developed, and are now testing in a small clinical trial a father, an enhancement to an early prevention strategy, which I'll talk about, that is more inclusive of fathers as service recipients. So that's sort of the overview. And depending upon time, we can do back and forth questions and answers and so forth. Okay? So that's sort of what I'd like to do in the next hour and a half or so. Okay, so to give you a little bit of context, these are data from the official records. So these are data from the official data systems that are at the national level in the United States on reports of physical child abuse and neglect, as well as sexual abuse. And I know there are similarities in Israel and differences as well, but in the simplest form, physical abuse, the term abuse is used legally as an act of commission. That is something the parent does that inflicts harm on the child. And neglect is used as an act of omission. That is something the parent fails to do that results in the harm of the child. Okay, that's the simplest form on the legal sense. And then based on that, then the state has grounds to intervene, and then we get some data on an intervention. Okay, so basically what this shows is data over the last 2 decades, since the early 1990s. Before this, by the way, if you were to go back since the late 60s when we started collecting data, you'd see the data way down here, and then you see an explosion of reports when the public became aware, when mandated reporting was instituted across the 50 states in the United States, and then there was a leveling off for quite a while. Okay? Now from the 90s, interestingly, we see on 2 forms of maltreatment, physical abuse and sexual abuse, we actually see meaningful declines in the number of reports. These are actually are substantiated cases. These are not alleged cases. These are cases that actually where a court found that indeed there was an incident of abuse or neglect. Okay? So we see actually in the hopeful sense, 55% decline in physical abuse and about 61% decline in cases of sexual abuse in the U.S. Child neglect has remained rather stable. And we oftentimes think of neglect as being closely associated, but not equivalent to poverty. There's probably one hypothesis is why the number has not come down as much. Okay, but those are hopeful data. But having said that, though, the other side of that is that even when we take these numbers here, we're still talking in the United States about 3.5 million children every year. Unique children. These are not reports. These are children that are reported for physical abuse or neglect in the United States each and every year. 3.6 million children. Okay, it's a staggering number. I mean, if you think about it. And those are only the official reports. Okay, so it's almost a certainty that the vast majority of forms of abuse or neglect never come to the attention of official reporters. So this is most certainly an underreporting of the case. Now, the even more troubling is the number, and this number has been rather steady over the last 2 decades or so, is the number of fatal cases of abuse and neglect. So the most recent year was, I think, in 2010, and the official records there, about 1,537 children were killed as a result of physical abuse and neglect in the United States. Okay. Now, just to give you a sense of magnitude, because obviously this U.S. is a much larger country in population, right? Okay.
How many?
So 1,537 kids, and that number, these are deaths as a result of abuse and neglect. Okay, fatal abuse and neglect. Okay. And that number has actually remained steady over the past probably 15 years at least. Okay, so that's obviously a very disturbing number. If we look at percent-wise, so in fact this is per 10,000. It's a little harder to translate that to percent. But if you add these up, it's essentially 1.5% of the children in the United States every year are officially reported for abuse and neglect. Okay, and that number is actually down from about 2.5%. So the numbers, there's an improvement, but in the absolute sense, obviously we have you still have a huge problem. If we think about the cost to the child, to the family, to society, to government's expenses and so forth, right? Okay, so that's partly the American context. Now, one of the other things I want to focus on here is I want to begin to focus on the early childhood years. From a maltreatment standpoint, early childhood is the period of the greatest risk and greatest vulnerability to the most severe forms of abuse and neglect. Okay, so for example, again, these are official data from actually 2009. It takes about a year for them to accumulate the data, clean it up, and so forth. But these numbers are essentially the same today, and they have been rather steady for the past decade or two. So you see that these are of the reports of substantiated or what we call indicated. These are the cases that were actually found to be abuse or neglect when it has occurred. That a third of all the reports occur in children that are 3, 2, 1, and 0. Okay, now if you do the math right, this is up to 18 years old, you see that that's an overrepresentation of reports. Because you would expect only 1/18 every year, right? And you get much more than 4/18 here. Right now, and also the other thing here is that, again, these are infants and toddlers here, right? So in the States, there are, I think, proportionally fewer kids, they're infants and toddlers that are in daycare immediately, where they will be seen by a mandated reporter. So that this also is almost certainly an under-reporting, differential to the rest of childhood, because then when children come into school systems, all teachers are mandated reporters in the United States now. Okay? So there's many more cases that go unreported in this, and yet nonetheless this number is a disproportionate number. Now when we look at the more incontrovertible data, that is fatalities. Okay, that is deaths as a result of abuse or neglect. We see that in fact 80% of those occur in children 3, 2, 1, and 0. Okay, so the early childhood, especially the first 3 years of life, are especially high risk. And there's a disproportionate number of kids that face the worst forms of abuse in the earliest years of life. And interestingly enough, if you even break up the first 3 years of life into subgroups, you even have a disproportionate number of reports and deaths in the first year of life. And in fact, if you even broke this up, by the way, you'd have the same thing. You'd have a disproportionate number of deaths in the first days of life. Okay? It's just sort of an exponential curve in terms of maltreatment fatalities. The younger the child, exponentially the higher risk. Okay? Now, so on the risk side, there's no question that there's a window of risk. And I also would say, and I'm sure some of you are familiar with some of the research in this area, that there's also a window of opportunity. I think Charlie, you've done some work in this area too, is in the first few years of life are uniquely characterized by the dynamic set of developmental sort of milestones that children and families go through that set a trajectory for the rest of life, I would say. So just on the neurological level even, for example, one fact that always stands out in my head, I'm not a neurologist, but from the second trimester prior to birth up to about 8 months of age, neurons in the nervous system are generating at 250,000 per minute. Right? So the neural system is just exploding with dynamism in the first few years, first few days of life, prenatally even, and then that tends to settle. The neurological development tends to settle, and neurons actually begin to become pruned away based on interactions with the environment, based on environmental stimuli, whether those neurons get activated or not. If they're not activated, they die. There's a settling in process at the physiological level, right? And at the psychological level as well. So we know that there are the development of primary attachments, for example, the development of the most fundamental lessons of life, and responding to environmental stimuli, language, walking, relating to other people, human relations. All the fundamental building blocks are put in place in just those first few years of life. So what I like to characterize early childhood as a window of both risk and opportunity, and it's a unique window then for us who are thinking about intervention, thinking about services, thinking about policy, to really have the greatest contribution, to make the greatest difference for vulnerable families, with the greatest return, if you will, greatest bang for buck, as we say in the colloquial English, right? So with that, then, I want to introduce you. Some of you are familiar with the strategy of home visiting services, which I've been working in for a while. This is in the face of the science that's been developing around, in the descriptive sense, around early childhood. We also have a science that's intervention science that's actually giving us quite a bit of hopeful data, not all positive, but hopeful data, on the fact that indeed, if we intervene early enough in the right way, we can alter developmental trajectories in a very long-term way. Okay? So that the intervention science even suggests that early childhood is also a window of opportunity. So the primary strategy that has been used, I won't go through the history, but in the United States and in a number of other countries in Europe, Australia, New Zealand as well, and there's maybe some parallels here in Israel. Whenever I talk about this, someone brings up tipat chalav. So I think that, okay, right, and then everyone says, well, it used to be. Exactly, not as much today. Right, but the strategy in these other countries I was mentioning is a strategy whereby a professional or a paraprofessional, first of all, families identify not because of a problem like abuse or neglect, not through the welfare department, but rather through a universal system that almost everyone uses, namely the healthcare system. Right? So almost every mom gives birth through the medical system. Right? In a hospital, or there's some doctor linkage and so forth. And that's a universal, non-stigmatizing system, unlike child protection. Right? So families are identified through a universal system. Some home visiting strategies will screen for risk, others will not. They'll focus on some demographic factors such as, is the mom a first-time mom? Right? Or does she live in this community that might be deemed as being a high-risk community? So then if the family is interested, services are offered voluntarily. There's no coercion. Again, unlike sort of the traditional child protection model, a worker will go and say, we have the service where someone can come into your home and help you learn how to be the best mom you can be. Right? Maybe how to change the diapers, how to take the baby's temperature, how to, and maybe we can link you up with some services in the community too that might be useful to you. And the large majority of families that are offered home visitation services proactively, voluntarily say yes to this. So I did a bit of a study of all the studies that have been done, and the range of engagement of families ranges between 71 and 92% of families say yes, I would like the service. Okay, that was the median of about 80%. 8 out of 10. Okay, so and the families then also tend to stay in the services because they're needed, they're voluntary, there's not someone coming in and saying, you did something wrong to your child. Okay? Services, as their name suggests, the worker does not expect the family to come to her, she goes to the family. And then she is able to work with the family in the indigenous environment in which the parenting is taking place. Right? In which mother's trying to learn how to breastfeed, for example. Right? Maybe the worker then can help her learn how the baby to latch on, help her manage the stress, give her some practical tips around, well, when the baby's sleeping, maybe you might want to sleep to catch up on some rest. Right? Or how to help baby-proof the home. It's much easier to do in the home than when make the mom come to the center. Okay? Some parenting education. The services are typically initiated at the point of birth or just before, some cases just after. And the important piece here is that these services are distinctive from the traditional approach to the problem of child abuse and neglect, in that the services are, as I said, voluntary. They're provided before there's any identified problem. Okay? And the focus is on supporting the family. The focus isn't on where's the problem, what's the risk to reduce. Okay? The goals are set by family, and the worker then works with the family on a regular basis, weekly, bi-weekly, making home visits. Okay? Any questions about that? Who's not included? Who gets screened in? Different models, so there's a number of different models now in the United States, in operation and actually in other countries. And different models will determine eligibility differently. So one model, for example, called the Healthy Families America model, will actually screen families at the point of a visit to a prenatal clinic using an individualized risk screen. And if the mother is socially isolated, if she shows depression, if she shows evidence of domestic violence, and so on, then she tends to get screened in. She gets a certain risk score. She'll get screened in, and others will get screened out. That's one strategy. Another major strategy in the U.S. is the nurse-family partnership strategy. That strategy doesn't screen at the individual level at all. So essentially the screen there is this a first-time parent? And is she in her third trimester? And the services are provided in this impoverished neighborhood, perhaps. So the screen, if you will, is a demographic screen rather than individual risk screen. Okay, make sense?
Yeah. What happened if they find that there was an abuse there? That the mother or someone.
So just like any teacher or early childhood worker in the States, at least, home visitors are also mandated reporters. Okay, and the workers, the families know this when they sign on. However, the focus of the service is not on maltreatment. In other words, to the family, that is. So, for example, if I'm going to your home, I'm not coming to you and saying, I'm coming to you because I want to prevent you from abusing your child. Do you want my service? Okay, you wouldn't get such high engagement rates, right? So the focus is on, I'm here to help you be the best mom you can be. Oh, and by the way, here's my legal requirements. Okay? And if for example, I see some undue risk, I'm going to help you in the best way I know how to prevent me from having to report you, and prevent your child from having any harm. Okay, so the focus is a positive frame, if you will. I'm here to serve you. I'm not here to report you. And I don't want to report you, except the law might require that I do. Okay?
אני may have missed it, but is it part of the health services more, the professional?
Right, that's a good question, Anna, because of course if you launch such services in a welfare system, for example, then you still have the tension around stigma, around who is the problem, who's not the problem, and so forth, right? So at least in the States and in the other countries I mentioned, Australia and in England, for example, the services are actually structurally lodged, for the most part, through the healthcare system, not through the welfare system.
And who,
Not
and who are the
exclusively.
professionals that are doing
That's
it?
another good question with a longer answer. But there are varieties, like Yona's question, there's a number of different models that we utilize different professionals or paraprofessionals. The model one model that has some good data behind it uses nurses. Another model that has some good data behind it uses paraprofessionals. And they're trained on the job. They don't have a higher degree necessarily, but there's a lot of intensive training. So there's a variety of personnel configurations. Okay, and we could go into that maybe more. Yeah, but I could digress on that for a while, which I don't think you want me to do.
Is there a way to characterize the group, the percentage who are not, who are refusing to get the home
Yeah,
visitation?
that is a really good question. So, and it leads to what I'm going to say in a moment, which is, this is, first and foremost, this is not a panacea strategy. That is, it doesn't solve the problem 100%. And one of the biggest challenges in this field are families that do not engage, and also another second very closely related challenge is families that do engage, but then begin to drop out before the dosage of the service is fully delivered. Okay, so, and that's a huge challenge. There are next generation strategies. I'm going to talk about one next generation strategy focused on fathers, but there are other next generation strategies that are focused on improving engagement and retention in the services. Okay, because that's clearly an Achilles heel, a little bit, of these services. Okay, and maybe a little exaggeration. Okay, so actually I think these last couple of questions speak to this. Now let me walk you through this. This is a bit of a technical slide, although you can probably get it. This is a graph of a meta-analysis of the randomized clinical trials of the home visiting strategy. And basically what is graphed is the magnitude of the positive impact of the home visiting service when compared against a randomly assigned control group. Okay? So what I mean by that, for example, is these are each studies. These are the first authors of each of the studies. This was done in 2003. I also did a meta-analysis in 2001 that arrays very similar to this. This is more elegant graphics of my own, so I like to use this one. And it has the signature of the Centers for Disease Control and Prevention on it, so it sounds a little quasi-official, I guess. But essentially, at zero, if one study, let's say the Kitzman study, lines at the 0 point, that means that there was no observed difference on child maltreatment when you compared those families that got the home visiting versus those that did not. Randomly assigned. These are only randomized clinical trials. Okay? So then when you look at studies on this side of the origin, on this side of the 0 point, these are positive preventive effects observed in the home visited families when compared against those that didn't get the home visiting. So for example, all of these studies over here showed positive benefit of the home visitation service. Okay? At the follow-up point. And actually, interestingly, there's a few that showed a negative impact. Oddly enough, we wouldn't want to see any of those actually. That the service, in fact, is linked with a poorer outcome than the lack of the service, right? But indeed, this is the science, right? And this is the data. The data are the data. However, one can partly explain these, not fully explain, but partly explain these because of what we call a monitoring bias. That is, the home visitor, when you think about those families getting home visiting service and those not, the home visitor is not only delivering a service, but she's also just watching what's going on in the family. And as I said earlier, she's a mandated reporter too. So because of the presence of her eyes in the home, there's a greater likelihood that families getting the service are going to be reported simply because of the monitoring bias, the eyes in the home bias. Okay, so it's a statistical artifact. It's not an empirical problem. Okay, that's only part of this, though. Okay, but what the CDC did is they said, well, if there's some bias here, then in fact all these numbers are biased in some way, shape, or form. Okay, what they did is two things. They said, let's calculate the average benefit across all the models we talk about. All the studies have been done using the gold standard scientific study design. And what they found is they calculated the average. That's what this dotted line is here. Okay, and they said basically for those families, on average, across all the models that have been getting home visiting service, there's been an average 40% fewer reports of child abuse and neglect than those families not getting the home visiting service. Okay? Now when they calculated in this bias I was talking about, that shifts the whole curve a bit more this way. So in fact they said this is 40% is a conservative number. More likely, if you include the bias, it's more like 60%. Okay? That's not a I happen to find that an exciting number. If we think that somewhere we can prevent about half of the cases of child abuse and neglect before they ever happen, with a relatively low tech, relatively low expense strategy, before there's ever a problem focus, without stigmatizing the family, without taking the children out of the home, and so forth. Okay? So that's a hopeful graph. However, one could also say, well, there's a large dispersion here. Okay, there's a variety of different studies and found different things. Some of them found not such good results, and some of them found rather good. But actually, you want to see even more this way. So what some of us in the field have been doing is that we've been trying to decompose these studies and find out what's linked with positive benefit, what's linked with negative benefit, negative outcomes, excuse me, and why don't we see even better outcomes here? Okay, for example, low engagement, we see families dropping out. There's a few limitations to what I would call a first generation of home visiting services. Okay, so there's a number of us now in the field that are working on what I call a second generation of home visiting strategies. We feel like this is a good place to begin. Very hopeful data, right? So one classic study, the David Old study, and this was a study conducted in Elmira, New York, in the mid-80s. Findings here were reported in 1986. Then David Olds followed up those same kids 15 years later through the span of childhood, and he found in his study that not only were child maltreatment reports lower through the span of childhood, but that the kids themselves also had fewer arrests. They used substances less frequently, illicit substances less frequently. The mothers were on public assistance less time. Their subsequent births were further apart. Okay, there were multiple positive outcomes that he saw as a result of 2 years of service during the perinatal phase. He didn't provide any service after the children were 2 years, and yet he saw these lifelong, or at least through the span of childhood, benefits as a result of something that was done in the first couple years of life. Okay, so, and we almost never see, frankly, I mean, I'm an intervention researcher. The reality is we almost never see sustained effects years out like that. It's very rare. So that's very exciting data. Overall, it's very exciting data. But this is first generation. We're not there yet. We haven't solved the problem yet. Okay, so what several of us have been doing is looking, can we augment, can we improve upon, can we extend the benefits in this early prevention strategy?
What is the first generation?
So the reason I say first generation is because primarily these are monolithic models that are, the focus is on one outcome, that is on maltreatment. But now as we begin to decompose this, we see that there are limitations like not the kind of engagement and retention we like. So now there are new strategies that we're adding on to these early pioneer models to make them better. But essentially what we're doing is we're taking the science and building a better model over time. We're using that data, we're looking at the outcome data, And we're looking at both the benefits of the outcome data as well as the limitations of those data. And we're trying to... Something urgent?
No, I tried to kill it.
Okay. Okay. So, and we're trying to build a better model based on what is a good beginning, a very good, helpful beginning, exciting beginning. Okay. So with that, then, there's several of us that are looking. For example, another example is in the area of maternal depression. So a number of studies have shown that maternal depression, especially during at the point of birth and after postpartum depression, is linked with maltreatment risk. But none of these models have actually sort of specifically targeted maternal depression. So now there's some of my colleagues that have built in an add-on to specifically target and provide specialized services for depressed moms. That's one example. That's a whole nother topic. And I'll let my colleague Bob Ehrman, who really has pulled that one together. What I'm going to do is talk about a different enhancement in a second. Okay. Part of what I've found here is the following: that interestingly, when you review all the randomized trials that have been done to date, you see that the services are designed for, delivered to, and the study subjects are all mothers and their babies. And there's not one of these yet that have focused on fathers. Okay, finally getting to the point. Okay. Okay, so why is that important? Okay, so what I want to do now is, to me, fathers are a huge missing piece to this service modality. Okay, and I'll go into a little bit on some of why that's the case, and then I'll talk a bit about a couple of studies that I've been engaged in on this topic. Okay. So, first off, if we look at the maltreatment data, okay, remember I was talking about child maltreatment fatalities, which especially are concentrated in early childhood. In fact, when we look at the data, the few studies that have been done, and these are studies that have basically reviewed death records and the causes of death, and then the official records around why that happened and so forth, who the perpetrator was in the case of an inflicted death. Okay? And we see that consistently fathers and also male figures like father surrogates are way overrepresented as the perpetrators of fatal, the most severe forms of child maltreatment. So for example, this is the National Violent Data Reporting System in the United States. 45% of the maltreatment fatalities were perpetrated by fathers and father surrogates. Now you'd say, well, that's less than half. Yes, but do fathers and father surrogates spend half the time with babies and their children? No, by no means, for the most part. Right, so again, when you think about the amount of time and exposure, if you will, that males and fathers have to children, the opportunity to carry out fatal maltreatment, it's way below what, in fact, that you would expect in terms of these actual incidence rates. Okay? Another study is consistent. This is shaken baby syndrome, which is a form of child maltreatment. Okay, this is in North Carolina. Again, 44% were perpetrated by fathers, 20% by boyfriends, 7% by mothers. Okay? 23%, this is another study of in Missouri. So multiple different points. These are all studies in the states so far that I'm aware of. 23% perpetrated by fathers, 44% by other males, and mothers 21%. Okay? So fathers and father figures, if you will, are way overrepresented as the perpetrators of the most severe forms of maltreatment. Did I see a question? No? Okay. Also then, so one of the things that I've been doing over the last 7 or 8 years is on the descriptive sense, trying to understand why that is and what's the father's role in understanding the perpetration of abuse and child neglect. And there's actually rather vague data on this. We don't have a clear picture yet. There are some studies, about a dozen studies or so, that have been conducted that look at what is it about fathers? What do fathers contribute? How do they challenge the parenting process? Is it they themselves? Is it what they do with the mother? Do they challenge mother's parenting? What is that all about? Is it what he brings to the home economically? Is it what he does in terms of how he relates to the mother? Is it how he relates to the child? Well, a lot of this we didn't have much of a clear picture of. And if we're thinking about designing strategies, services, and policies, we have to have something to go on, or else it's likely those strategies are not going to do very well. Okay, so there's a few studies out, but not too many. There are several studies that have pointed out, these are 70s and 80s and 90s, that have pointed out, well, that single motherhood, for example, is a risk factor for physical abuse and neglect. However, those studies now, we understand that that's really a substantial oversimplification of the problem. It's not just that because a mother's single, she's therefore at higher risk of maltreatment by any means. Because the studies that have been done subsequent to that point out that, in fact, there are all kinds of parenting arrangements and relational arrangements, beyond whether just the mother's married or not. And even within marriage, there are all kinds of relational patterns, right, that are linked with untoward outcomes, okay? So there is a correlation, but in fact, in a moment, I'll show you that single parenthood in and of itself is not a risk factor for maltreatment, okay? There are some studies, though, actually we just published one rather recently, that links in a rather intuitive way, if fathers are positively involved with their children, then not only is his maltreatment risk lower, but so is mother's maltreatment risk lower. Okay? And this is after controlling for a whole variety of other extraneous kinds of variables. There are several studies that link father's abuse and coercion toward the mother with maltreatment. Muhammad knows this very well. So there's a couple of classic studies actually look at these death review panels and have said that the several studies have been done and pointed out about between 40 and 60% of the cases where there is fatal maltreatment, there was also the presence of domestic violence. Okay? And then there are some studies that actually look, one study that's actually looked over time, if there's domestic violence, is at a subsequent point in time, is there greater likelihood of maltreatment? And indeed, we see that that is the case. The one study suggested, it was done by Mark Chaffin a few years ago, suggested that there's about a tripling of the risk for maltreatment subsequent to domestic violence. Okay? So that is, there is a growing amount of data that suggests, yeah, there's probably something causal there. Right? These, well, what's the causality? It's very unclear to say what the causality especially is here. There's a few studies that have pointed out that when father and mother relationship more generally is not terribly positive, is undermining or not sustaining for the mother, it actually predicts mother's maltreatment risk. Okay? Again, these are correlational studies, however. They're not causal studies. So it's hard to tease out what might cause what. Okay? We have only a crude data base to draw from at this point to help us figure out, well, what is it about fathers that that we should be targeting, for example, in services. Okay, ultimately, as an intervention researcher, that's what I'm interested in. Is, okay, this is descriptively interesting, but what do we do about that? Okay, and so, so we've scoured the literature in the descriptive sense. Here, there's a couple of studies here that have linked fathers' abuse, substance abuse, and alcohol abuse with maltreatment risk. Oh, I'm sorry, that's the Mark Chaffin study that prospectively pointed out father's abuse of a substance with later physical abuse and neglect. Now, this is interesting. There's several studies now. Most of us would think that it's rather obvious. If the father's unemployed, he's not bringing any economic resources into the home. There's several studies that suggest, well, fathers can act out more coercively when they're unemployed. or there can be some depression in the home, therefore they might put the child at risk in some way. The studies that have been done to look at not only how much money he brings to the home, but also whether he's unemployed or not, they're actually mixed findings. There's simply, one study says yes, one study says no. And there's not a clear picture yet in the literature. And then finally, we've done a study, as I said earlier, where single-parented per se, marriage, whether parents are married or not, is not, when you look at other factors like parents' education level, the quality of the parenting, the quality of the relationship, when you parse out those factors, then in fact marriage drops out as a protective factor for maltreatment.
We shouldn't have published that.
Yeah, no, that's right. Actually, for reviewers, I got a lot of feedback on that. It's rather controversial, right, to say that. And in fact, the more controversial piece was when we parsed out all of the other variables. In a couple of cases, we saw marriage as being linked with higher risk for maltreatment. Okay, mother's physical abuse. It wasn't neglect. We weren't looking at neglect, but we did see some. So that's, and I can't easily explain that. Okay, but what again, the picture around what a father's, the empirical picture of father's role in the maltreatment equation is still a very murky one. Okay, but we know that they're important. We also know that fathers are important in a variety of other outcomes, not only maltreatment. So there's a number of studies of mother-infant attachment quality being shaped or correlated with quality of father's involvement. Father's involvement with the child, positive involvement with the child is linked with children's academic outcomes and cognitive development, and even father's positive involvement with the children, not surprisingly, then also, if it's linked with maltreatment, is also linked with children's aggression, delinquency, depression, and anxiety. Okay, so there's a growing mound of evidence that suggests, oops, we've overlooked that. You know, they're really important in children. They're really important in children's outcomes. Now, with regard to child maltreatment prevention services per se, there's actually a growing number of studies that indicate that fathers not only shape children's well-being, but they actually shape the impact of the service. Okay, so I was mentioning the David Old's model in Elmira that found these long-term, through the span of childhood outcomes, which are very exciting. Yet, John Eckenrode at Cornell University actually looked at those same data and reanalyzed the data, and he looked at, well, what happens in cases where there's domestic violence, where the father's abusive of the mother? Okay, and what happens, and let's compare those where there is a significant amount of abuse versus those where there's not. And in fact, he found that where there was a significant amount of domestic violence, the home visitation that I said was so exciting, the impact of that was nil. Okay? It was unobservable. So it's only the impact of the service was only observable in the families where there was no domestic violence.
So I wonder, is the question, is it the importance is of another person being there to support the mother, or the father as a father? Or
Good
do you know
question.
something about it? Because
Good question. It's a good question. I think it's a complicated question. Clearly support is important, right? But I think, let me go a little further into this, because I think that might push your question even further a bit, okay? There's also a couple of questions here, a couple of studies here that say that when there's not good support with a significant other, in most cases that's the father or a father figure, then mothers drop out of services sooner. So it goes back to this question of engagement and retention in services, which again is, as I said, partly an Achilles heel to the home visiting model. So fathers apparently play some role in that Achilles heel, right? That maybe if they're not supportive of the mother being involved in service, maybe the engagement is not as deep, potentially. Okay, that's what this seems to suggest. Okay, and father's involvement with the child also moderates the impact of the service. So let me give you some data from a study that I conducted recently. I'll show you this graphically in a second. But this is we conducted a randomized clinical trial of a home-based service intervention for families at high risk for maltreatment. We enrolled, these are in 6 home visiting programs in North Carolina. We enrolled families over a couple-year period, enrolled 101 families, collected data pre-test and post-test, looked at maltreatment risk pre and post. Randomly assigned half to either get the service or have to get a case management only service, where they're not also getting the home-based service. So it's a randomized trial. And then we looked at outcomes. So here's 2 outcomes. One is psychological aggression toward the child. This is mother's self-report. And this is mother's self-report of her assault of the child. Okay, using the conflict tactics scale. Some of you will know this well. And then what we did is these are control variables, because we found that at baseline they differed. So we factored out the statistical influence of these in the outcomes. We look at, first of all, the intervention group versus, this is the parent aid service plus the case management service compared against randomly assigned case management service only. We see some impact here, positive impact. On psychological aggression, we don't see impact with regard to physical aggression. When we factor in the father's involvement with the child, this is an interaction term, so this is a moderator analysis, if you will. Does father's involvement with the child moderate the impact of the service? Does it alter the impact of the service? And here we see statistically significant outcomes. The father's involvement with the child plays a role in the preventive benefit of the service. How so? So let me just graph that for you, okay? So if you look here, what we did is a median split between the families where there was a more highly involved father versus those where the father was not well involved. And here we see, this is the families that got the parent aid service. These are the families that did receive the parent aid service compared against the control group. Okay, this is exactly what you like to see. As the control group families, risk got higher. The parent aid service families, the risk reduced. Okay? However, that was not the case. In fact, it's the reverse when fathers were not highly involved in the service. Okay, so the risk actually increased even for families that were getting the parent aid service. Okay, for families where the father was not well involved with the child. Okay? So that's what we call a moderator effect. Father's involvement with the child moderates the impact of the parent aid service. We can also look at then, not only fathers involved with the child, but are they involved with the service? Okay? And we see essentially the same pattern. Again, in cases where the father is well engaged with the service, we see the risk decline in comparison to the control group. And when fathers are not well engaged, we see the risk, again, continue to increase. Okay? So all of this work of the service, and yet we see that there's only some benefit. There's only cases where fathers are well involved in the service and well involved with the child. And we actually see the reverse effect when fathers are not well involved with the service and when fathers are not well involved with the child. And similar graph, this is on just the second outcome, on psychological aggression, essentially the same pattern. You see the reverse slopes. Okay? Across whether fathers are well involved with service, in this case, engaged with service or not. Okay? Question? Let me stop there for a second, see if there's any questions.
Just
Yeah, please, either way.
I was wondering about other aspects like socio-economical aspects or political aspects like exclusion.
Right.
So where are these factors connected, or how are they connected to the involvement of the father or to success of the intervention?
Right. So on both of those variables, social exclusion variable, or social political exclusion, and on socioeconomic status, if you will. In both of those cases, it's very hard to tease that out from the data, not only in my study, but in the other studies. The reason being is that most of the, if we go back to this, this one here, that there, okay, where there are multiple studies represented. Almost all of these families are poor families across every study. And in most of the cases, I mean, one, I guess, could use race as a form of social exclusion in the States. So interestingly, if you look at, if you compare studies where there's African American or primarily African American samples versus white samples versus Latino samples, you know that states like Israel is a multi-ethnic society. It's hard to generalize, and this is probably going to be an overgeneralization. The outcomes is hard to tell. However, with regard to engagement, in fact, we see a mildly higher engagement rates for minority families with home visiting services. Why that is, I don't know. I can't answer. However, some models of service use a home visitor from the same community, the same ethnic background, if you will, as the family receiving service. So there has been the argument, no one's ever tested it yet, but there's the argument that the ethnic matching, or the community matching between worker and service recipient is a beneficial strategy. But it's practice wisdom. There's no data that says, yes, that's right. You know, yeah. So it's hard to give the full answer to that. We mostly don't know the answer to that, partly because there's a floor effect. That is, almost all these families, and even in my study, the families were all impoverished. I did do analysis in these data I showed you here. These data, were the differences across white families versus black families. We had about 2/3 white families in our sample and about 1/3 black families in our sample. We didn't see any difference. But that's just a crude proxy, I realize, for social exclusion. And socioeconomic status, we're all 100% impoverished families. Okay? Charlie, do you have a question?
First of all, I have to apologize because I have to go.
Please, I understand.
But I just wanted to offer a possible explanation for this effect, which you may have thought of and may be in the article. And that is that there could be a pernicious effect of the program on fathers if they are not included in the program, if they're not involved.
That's right.
The program, we saw this in a study that we did on another topic a number of years ago, that if the program, most of the programs, one way or another, concentrate on the mother.
Yeah.
And if the father is not involved, he feels even more out of that,
Exactly.
and could even be more resentful. I'm not
or threatened even,
or
perhaps.
Yes.
That here's someone coming in and doing something with my partner, helping her out, and I'm out of the picture. So it could, I think that's my theory also. I think it's very much in line with what I'm thinking, is that there might be some tension between informal supports and formal supports. We've seen this in the self-help field, for example. The self-help movement strategies, sometimes there's an inherent tension between indigenous support and professional support. And I think that, I'll speak to that when I get to talking about this intervention trial we've begun to work on. Because we're very mindful of that. Thank you for that comment. Another question?
If you can say something about the factors that are related with better results in this home visiting services. Because you see a lot of variability, so what are the factors that are related to
I see. So if we go back right to, okay, so I'll summarize that briefly because that's almost another talk in itself. No, that's okay. That's a good question. So in other words, you're saying, why are there some over here and some over here, and what's the difference between the two, right? Is that sort of your question? So there are some differences that one can notice. They characterize these programs in contrast to these. I don't have the slide with me, but I'll summarize a few of them. One of the clearest differences is that these programs tend to deliver services more intensively. And these services tend to be less intense. Now, the dividing line appears to be bi-weekly or more frequently. That tends to be these programs over here. And when the home visitor, this goes back to, I think, Tipat Chalav, maybe, right? Because I understand, has not Tipat Chalav become a little less intensive over the years, or not? Is that not accurate?
Yeah.
It is accurate.
Yep.
So service intensity appears to be one of the clearest, not service length, by the way. It's not 5 years versus 6 months. It's the intensity of the service. How concentrated is the service? Okay, that is rather clearly linked with positive benefits, as opposed to these programs that tend to be over here. Okay? There's another, this is a more complicated answer, and another complicated trend, but these programs over here, I think it goes back to Yona's question about enrollment and screening and who gets in and who doesn't. These programs on this side tend to be those programs that did not screen at the individual level, like I was describing before. Mothers that are depressed, therefore get higher score on the risk assessment and therefore are more likely to get the service. And the ones that are lower risk get screened out. Okay? Now, in fact, these programs over here tend to be those that don't use any of that screening, but rather will use the demographic level of enrollment. Okay, so for example, in an impoverished neighborhood, or first-time parent only. Okay? And the explanation, there's several explanations that I offer there. One is that when you screen in families with certain risk profiles, again, let's say a depressed mom, or a family where there's substance abuse, the service strategies, this is why it goes back to my point about first generation models and second generation, is the service strategy hasn't caught up with the risk profiles. So you might be, these kinds of programs over here tend to screen in high-risk families for depression, for substance abuse, for social isolation, but the intervention itself doesn't necessarily target those especially complicated kind of problems. Okay? So therefore you get, I think that individualized risk screening tends to exacerbate a mismatch between the service and the need. Okay? Whereas here you see less of that. Alright? So that's a second rather clear trend in the data. There's a couple of other trends that I'll speak only briefly about. One is those programs, and I want to also say these programs are not only targeting abuse and neglect prevention, they're also targeting low birth weight, they're targeting cognitive readiness to start preschool and kindergarten. Okay? They're targeting a variety of outcomes for families at risk. And there are several studies on this side that have targeted poor health outcomes. And the programs that actually include a clear health component in the service, like prevention of poisons, baby-proofing the home for accidents, that kind of taking the baby's temperature, those actually also tend to be on this side of the table, as opposed to over here. Okay? So there's a few trends, but that's sort of crude. It's not so easy to say, okay, here's the magic answer, here's the right pill, here's the right intervention that will solve them all. Because as you can see, the families are less isolated, maybe? Well, I wouldn't say that necessarily. But what I'm saying is that some of these programs over here tend to use as one of the risk markers whether families are isolated or not. So these could be, among other risk factors, they could be more isolated. It's possible, yes. That's a complicated question, this isolation. I can talk about that more, too, as we have time. Okay, so that's another question before we move forward. Okay, so given this then, given that we see that fathers have been overlooked in early prevention services, given that we see that they're important in children's outcomes in a variety of ways, they play a key role in outcomes on maltreatment, they also play an important role on the service itself. So what role dad plays can actually hinder or facilitate the impact of the service. We then set out to design a second generation enhancement to home visiting services that is fully inclusive of fathers. Okay? And this is sort of a window into a study that's happening right now. So I can just talk about the process of the study. I don't yet have the outcomes. But what we've done is we've essentially said, okay, we got to do something about dads in the context of this early prevention strategy called home visiting, because none of the other programs have yet done that. Okay, we know David Olds, I mentioned him earlier, he's adding on an enhancement for families where there's domestic violence, as is a project at Johns Hopkins University. So there's a couple of programs now that are starting to look specifically at the problem of domestic violence, when there's domestic violence in a family. But as we see from the data here, fathers play multiple other roles in influencing children's outcomes, and whether they're just hitting their partners or not, or coercing their partners or not. Okay? So we wanted to do a broader approach that was fully inclusive of dad's positive and not so positive influences on children and their families. Okay, so we basically began to scour the empirical literature, which you see is rather crude, looked at the intervention literature, which there's almost nothing on at this point. There was one study we were able to come up with that was of a group-based intervention for fathers whose families were receiving Head Start services, which is sort of a cousin program to home visiting. So we learned a couple of things from what they were doing. But we felt that group-based, one of the things that we found with a group-based intervention is that, in fact, it goes back to this challenge of engagement. The vast majority of dads that get invited to groups don't come in the first place. And we suspect that some of the most dads that could benefit the most would not come to a father's group. So we felt like we had to, and we actually ran then some focus groups with professionals, with mothers and fathers. And the professionals said, yeah, groups, we try groups and dads don't, we get 4 or 5 dads maybe, but we only get 5 or 10% of all the dads. Right? So we said, okay, a group-based intervention might be good for a few dads, but really the way to do this is through the vehicle of the home visitor herself. Interestingly, home visitors in America, almost 100% are women. Okay? So we asked this question when we ran focus groups to the professionals, to mothers, to fathers. Actually, the fathers themselves that we interviewed said, I asked them, would it matter to you if someone that responded to your needs was a male or female? And some of them said, actually, I'd prefer female. It's really counterintuitive because most of what's going on in the States right now is males doing fathers groups. It's in vogue, right now. But I don't know that that's the way to go. So with some of those focus group data, some of the prior empirical group data, we then basically blueprinted an intervention enhancement. We actually wrote about a 65-page intervention manual, okay, for the home visitors, and we showed it to the home visitors. We sort of cleaned it up a bit, and then we're now in the point where we're running a small pilot study or small clinical trial. We enrolled, before we trained the families in this enhancement, we just collected pre and post test data on a small number of about 10 families or so that we have at least some comparison group. We don't have enough money to do a large randomized trial yet, and it would be premature because we don't have any early data on whether what we're doing has any good benefit or not, or whether we can even enroll all the fathers or not. So we want to collect some preliminary data to show feasibility, to show some positive trends, and we now are in the second phase where we've now trained home visitors to deliver a father enhancement, if you will. We call it Dads Matter. And we have trained home visitors, and we're providing the weekly supervision to the home visitors. And these are in 3 different home visiting programs that represent different models that I talked about in Chicago. One in Evanston, 2 in Evanston. 2 in Evanston, where you're from, and one in Chicago. And then we are basically watching what happens, and we are collecting pre-test, post-test data, and we're actually collecting, interestingly, we're collecting audio recorded data on interaction between parents and the babies. So we're watching the verbalizations with a little recording device that the baby wears for 8 hours. And we thought parents would go, no, we don't want that. But in fact, they enjoy it. They want to hear themselves, and we'll give them the recordings back. So, but what this device does is it can separate out mothers initiated conversation with the baby, fathers initiated conversation with the baby based on the frequencies, and then baby's responses back to the parent. So we're looking at, linguistically, we're looking at reciprocal communication. Mothers, fathers. I haven't looked at the data yet, but we're getting a good amount of response rate and data on babies.
How old are the babies?
The babies are ranging from 0 to 3 at this point. Yeah, I think we have a 2.5-year-old in the sample. It's a small sample right now, it's just a pilot. So, yeah, some of them are newborns and some of them are a little older. Yeah, and that's a good question because obviously there's different phases even within the first couple of years of life. Right? So we're collecting pre and post data, and we're watching what happens. And I can tell you briefly what the intervention itself consists of, but it basically takes lessons from what I just presented to you. So what we start off, the primary strategy is focused on engaging fathers, because we feel like if you can't engage the father, you've got nothing. Okay? So, and we see that fathers shape mother's own engagement. So if we can engage fathers, we think we can also enhance mother's engagement. Okay? So part of the enhancement is training the workers simply to open up and be inclusive in her engagement process of both mothers and fathers. So not to say to the mother, by the way, I'll come to your home every week, and oh, if you want dad to come, bakasha. Right? No. You're part of the service and you're part of the service. I want you both to come. And if we can't meet together, then we'll make separate appointments. Okay, now in some families, there's multiple family constellations. Right? So dads in some cases are living in the home, in some cases not living in the home. Sometimes mom and dads don't talk to each other. Sometimes there's conflict between the two. Sometimes they get along pretty well. And there's a whole variety of everything in between. Right? So this is not a one-size-fits-all intervention. We train the workers to adapt and to nonetheless still deliver father involvement and inclusion services.
So the topics are similar for both the men and the women? Is there anything exclusive for men?
Yeah, yeah, but what we're interestingly, that's a good question. Interesting, where we're at primarily is we found that mostly what the study is in the pilot is a father engagement study. Because if you can't engage the dad, then you can't do anything else, right? So a lot of what we're focusing on is simply reaching out to the dads in creative ways and helping the moms and dads work together as a co-parenting team. Okay? So, let's see, do I have another slide on that? Yes, okay. So, no, I'm sorry. Maybe it's on here. No, I'm sorry. I'll just say it to you. Which is that there's essentially 3 principal sort of components to this intervention. One is a father inclusion or father engagement component. One is a co-parenting component, which essentially helps the mother and father work better as a team regardless of the nature of their relationship. Okay? And then the third is a father-focused set of strategies, which includes something like stress management for the dad, help seeking for the dad, problem solving, those kinds of sort of things that the dads told us. And one of them is anger management too.
That's what we call learning on success.
Okay. Okay. How so?
By the way.
We are learning from what we're trying to succeed and learn from it. So, so we have this manualized intervention with those 3 general components, but most of our work we're finding is really in the first component and sometimes then on the second, which is that once we get to the second and the dads are well engaged, then we're trying to help the mother and father work better as a team together through helping them do mutual problem solving, helping them communicate more effectively with each other around the child. This is not a therapy intervention. It's not family therapy. but there's some family therapeutic principles in mind, right? Which is to build the alliance with the parenting subsystem, that kind of thing. Okay? So, so that's what we're trying to do. Oh, and then, so I cannot share with you outcome data yet. I mean, literally, we still have several more families in our trial that we're providing clinical supervision on, and we'll be collecting post-test data on.
How long is
The study?
How long is the intervention?
Right. So again, if you think about what I said, is it's the primary focus is on engagement and inclusion of fathers. So the intervention begins at the same time that the intervention begins for the mothers. They're integrated, and then our enhancement we think of as about a 3-month enhancement, because we think after that, then the workers now are working with them as a team and doing, at that point, the much of what the worker can do with the mother, she can do with the father, parenting skill, stress management, linking up with community supports and so forth. But there's this adaptive piece that we think is critical at the very first few moments of in-service engagement. So there's a couple of studies that didn't put up here that point out that at the point of birth, dads tend to be, especially those that are highest risk, tend to be the most engaged with the family. Well, we don't actually choose the families. These are the home visiting programs that make their own intake process. And then when the families are when the dad is accessible in some way, for example, if he's not incarcerated or if he's not in another state, as long as he's potentially engageable, then we've asked all those 3 home visiting programs, or 4 actually, to refer cases to our project, and otherwise we don't screen out any other cases. Okay. And so we'll hopefully come back and tell you some of the results, but I can say on the anecdotal end, so with regard to engagement, we have in the intervention phase, we have engaged 85% of the dads in the service itself. So that looks sort of hopeful to us. Considering that, again, the baseline is that home visiting programs essentially only engage dads as an afterthought, even if they even do that. Colin, do you have a question? No. So I think at that point, I can provide some summary comments, but let's see if there's questions here at this point. Or maybe I'll just sort of summarize, and then we can open up to some questions and answers. Which is the point that I've been trying to make, especially in the latter half of the talk. Home visiting as a strategy is a very hopeful strategy. There's a lot of progress we've made. There's a lot of evidence base that we have now developed that these services can be beneficial to some families when they're delivered properly, when they're designed properly, and so forth. Okay? And in fact can prevent amounts of abuse and neglect before it ever occurs in the highest risk phase of life and alter developmental trajectories. So that's very, very promising. But there are limitations to the service model on a variety of fronts. I mentioned depression, substance abuse is another one, engagement is another one. What I've been focusing on is on the inclusion of dads in such services because of the empirical literature now that says, boy, dads are really important for kids. You know, one could have said that a long time ago, but now we've got the data there. And there are shifts in family patterns and so forth that are occurring as well. So that I think what the descriptive data suggests is that we need to rethink more father-inclusive practices as well as policies for children at risk. And that what we've done, what we learned in our pilot and our focus groups, and from the data around the importance of father support and the importance of the quality of that relationship for the child, is that we think that it's important to think about co-parenting as an important strategy or principle in serving a child. Okay. As I said before, there are multiple kinds of fathers and fathering relationships. across multiple ethnicities, across multiple classes, across multiple familial families and so forth. So whatever strategies we employ, they have to be very flexible and adaptable. Okay? And that it's important to fit the practice and policy strategies to what we're now understanding are those risk and protective elements that fathers bring to families. Okay? And as I mentioned in our pilot, it's important to communicate and engage at the very beginning, just like we do with mothers. Okay, and this is sort of I always conclude as an academic with we need to know more. But we really don't. There's still a developing knowledge base here. We still don't know a lot on the descriptive end. We certainly don't know much on the intervention end around how to include fathers, how to expand the impact of such services. And so we need to do more. We're just beginning. So with that, I will open up to questions.
And with the risk and protective elements very important. Because it's not that I think that the differentiation between the one, which is the potential for harming, the potential for having.
Right, that's right. That's right. And
very high. I think you should highlight.
Yeah, thank you. And with regard to fathers, I think it's especially true. So colloquially, when I go and talk about that I do work with fathers and prevention, people most quickly think of the risk elements that fathers bring to families without thinking about the protective elements that fathers also bring to families. The positive family and uplifting family nurturing elements.
Because fathers are, especially world class and very, very clinics working until today, they are totally neglected and also almost totally. This is really a call to arms.
Yeah, I think you're right. And I think that as service providers, we tend to create a self-fulfilling prophecy. That is that we tend to think fathers are not important, they're not engageable, or if they are engageable, well, they're not really that, they're not that consequential for the child. And if we do that, we telegraph that to the parents, to the fathers. And fathers then get that message, and they self-internalize that. And I think it does take a shift in thinking. The fathers are important as well. And I think in our pilot, we've been surprised at how many fathers we've been able to engage with female home visitors too, right, through existing services. So we'll see, but I agree with you that the service, we as service providers, in some ways, are also culpable. We have responsibility, if you put the positive frame on it, to reach out to the family system, not just part of the family system. Other comments or questions?
I'm still a bit puzzled, or not sure I understand the differences between the home visitation programs, because you tend to treat them as a one.
Yeah, they're quite different.
As one thing, but you mentioned they're different in their intensity.
Yes, right.
But I guess there are some other differences. And my question is, well, I have two questions. One, if you could elaborate a little bit about the differences between the programs, and how do you deal with that in your pilot study?
Right.
When you have, 3 different types of programs with so few families. Is it 20 altogether, or 20?
Yeah, 20 altogether.
Yeah.
We're hoping to grow it beyond that.
But even, even if you double that and you have 3 treatment models,
no, that's right.
I would say that even for a pilot, it's...
They're not that dramatically different.
Okay, so...
But you're right, we're trying to design the enhancement so that it fits with all kinds of different models. So I think it's you raise a really good point. And, but you see, all of the home visiting programs have certain commonalities that we're sort of linking off of, right? They all engage families during the perinatal phase, right? So we're building off of that. Fathers are, the descriptive data indicate fathers tend to be most involved. Even those that become less involved, they tend to be most involved during the perinatal phase. That's the other reason why we think home visiting is a good opportunity in terms of service delivery to fathers, is because we think if we wait till the children are 2, 3, they go into preschool or daycare, we think fathers tend to be less accessible, less engageable. So there are some commonalities that we're working off of. The programs, are going back to your first part of your question, which is that the programs do differ quite a bit in terms of the curriculum that they deliver, the actual contents that they deliver on parenting. Some of them actually have very structured curricula, session by session by session. Others, well, let's see what the family need is. It's more client-centered, if you will. And so the process and the content of the service delivery differs. The professional status or the status of the home visitor differs. Some programs, I think I mentioned, are used on-the-job training paraprofessionals. Others use psychologists. Others use nurses. Not even psychosocial professionals, if you will, although these nurses are trained to deliver that psychosocial content. Right? So there's a variety of personnel configurations. There's a variety of service intensities. There's differences on screening. So there are, and another interesting difference that's a little controversial is the David Olds model that I mentioned only will enroll families when they're having their first child. And if the family is about to have their second child, that family is ineligible for that service. Okay? Because from his model, there's a window of opportunity when a family is transitioning into being parents for the first time. Okay? That is a unique window of intervention opportunity to make even more difference, right? And with the second, third child, his view is it's sort of too late. The patterns are set, it's more settled. Other models don't take that point of view, and they will take first child family, second child family, fourth, fifth, and so forth. So there are variations on some of these important variables that create a little bit of interesting debate in the field. Yeah, lively debate sometimes. Although mine is very civilized. Other questions or comments? Or? Yeah?
I have a question. If you start with the home visitation setting, and on the way you find that there is another problem of domestic violence,
right.
What do you do? Do you try to combine two interventions? You would do
right.
a shift, or what do you do?
That's a good question. So like in our pilot, for example,
yes.
So we do have a domestic violence screening process. But I think your point's a really good one, which is sometimes not the first visit do you know what's going on in the relationship.
Yes.
Sometimes it takes a while. Sometimes you never learn, right? But there are times, maybe down the road, where the mother then feels more engaged and more comfortable with the home visitor, and now she begins to say, right? Yes. He's hitting me, he's harming me, he's coercing me, he's not letting me out, whatever, right? So that's then, at that point, at least in our intervention, we do have a domestic violence screen and safety plan process, which is sort of classic DV, intimate partner violence strategy. We don't feel like we're the experts in domestic violence per se, so we adapted what we think the experts and the data suggest are the optimal strategies. So there's a screening process. We train the workers to be ever mindful and keep listening for domestic violence. And when they hear that, then in addition to the screening, there's a safety plan. There's also then referral to resources for the mother if need be. So we do add on a little bit to our add-on, right? So it's in some ways our intervention. What we've done is try to pull from evidence-based strategies wherever we can find them, and that support what we're trying to do in a broad sense. And clearly, domestic violence in some cases, but not all cases, is an important consideration. So we have included that in our co-parenting piece, but it's all throughout.
Do you have any experience with volunteer personnel and personnel from the community?
Right, yes. Most of the programs that we use, well, when you say volunteer, do you mean a paraprofessional or do you mean someone who's not paid? Or?
I'm not sure about
Okay, so, right.
To ask about who.
No, that's okay, right. So, in this parent aid study where I put the graphs on the board, those were some volunteers and some paid paraprofessionals. So we certainly enrolled families that received services from both. We didn't have a large enough sample to see if there's any differences But what then in this Dads Matter pilot that we're running, all of the programs that we're working with use paraprofessionals as the home visitor. And by paraprofessional, I mean someone that doesn't have the master's degree or have the specialized training in social work, or some of them have specialized training in early childhood, but they don't necessarily have the parenting or the family training. So they're trained on the job. So when I say paraprofessional, I mean trained on the job rather than at the university and then trained on the job, right? And most of the programs, I would say by number in the United States, are paraprofessional programs. Partly that's just a cost thing. The more the professionals have higher salaries and they cost more, and states tend to look at cost as well, because the programs are not necessarily federally dictated. Okay, the federal government now has money that it disperses to the states, but the states determine what kind of programs they implement, 50 states. Okay, and they make different decisions. And many of them, we're in a very resource-constrained time. Many of them tend to look for the cheapest, but also showing efficacy models. And so they're tending to look more toward the paraprofessionals. That's not always the case, though. There are some states that are focusing on more expensive models. The nurse-family partnership, because some have argued that it has a stronger empirical backing, if you will. I'm not sure I fully agree with that, but...
So on the unpaid personnel, there's another thing that goes with it. Sometimes it makes a contribution to the interaction with the people, because when they know you are volunteering, sometimes it makes it more intimate.
Yeah, right, and more mutual in some sense, right? So the power differential is different. So there's been some argument in this. As I said, there's some lively debate around some of these issues. So this is one of the areas where there's been lively debate. So the nurse-family partnership model only uses nurses. That's why it's called nurse-family partnership. Okay, nurses are, from David Olson's point of view, are the primary preferred service deliverer, right? Others have said, no, not necessarily. Okay, and there's been some debate around that. And what David Olson has argued is that nurses have authority that they bring to the home that benefits them. Okay? That, in other words, I'm a nurse, I have some expertise that I can give to you. And he's argued, in fact, that opens the engagement rather than hinders the engagement. Okay? That's his point of view. There are others on the other side that have said, well, no, actually, if someone's more like me, maybe the color of my skin, maybe the language I speak, maybe where I come from, the community I live in, I'm more likely to bond with that person than a nurse from a healthcare system who may or may not live in my community, right? And therefore, because I bond in this way rather than in this way, I maybe benefit more. So there's a debate. And frankly, the data just don't bear out what the answer is. Although I think if David Olds were here, he'd say, yes, the data in fact do bear out that nurses are preferred. But I don't agree with that. There's a debate. Okay? Other questions? Yeah.
And just to read from the public health point of view, first of all, I've never heard anything in presentation which includes fathers, public health, and early childhood, which in itself is no minor.
Right, oversight.
Really, it's very, very, very important.
Right.
I wanted to ask the following. What kind of, do you have any indicators of what parents are the highest, what fathers are the highest risk? That's number one.
Yeah.
And you're dealing with secondary prevention, not the primary prevention.
Well, it depends on how you
Well,
define it.
if the child is born, it's secondary.
Okay. Yeah.
No, the first, no, it's an important point, because this is also the preparation for parenthood, whether the fathers are included, which we are not.
Prenatally, you're saying?
Yes.
Yeah, right.
That's what I mean. That's, and I want to ask, which children, do you know which children are most endangered by fathers' negative contribution?
which children are at the highest risk of being
Yes,
abused or
yes,
neglected?
yes. I mean, in terms of age, of sex, of
Yes, there
whatever
is
it
a
is,
little bit of
family.
data, but this is also controversial data, because some in the field say, well, if you focus on the child, you actually inadvertently tend to blame the child. I realize that's not your question.
Not really.
Right. But, for example, there is some data, I'll handle this question first, is that children that are born premature have some developmental delays, right? That have an insecure attachment, are inconsolable, they have colic, right? So there are studies that have linked these kinds of children with higher risk. No, they're published, no question.
No, not the studies, but most should know that.
Yes, right, that's right, definitely. And that's right, and the workers are trained on how to help the mother console the child, for example, when the child is screaming at 3 in the morning for 3 hours. I remember that very well, my own oldest. And I remember thinking, I now know why people maltreat their children.
Why don't you shake it a bit?
Yeah, right. Or, yeah, I mean, my impulse was, how about out the window? I said, oh my God, I'm having that thought. I'm in my own head.
That's
And I'm
when
a
you're
child.
married, right?
Yeah, right. That's right. That's right. So, you know, these things test any parent, right? Back to your point about risks for fathers. I think I would just go back to, sorry, this is a little slow here. Okay, this is really the risk profile, if you will. Okay, fathers, when they're not around, when they're not possibly involved with the child, this is what the data say at this point. When they're coercive to the mother, when the quality of the relationship with the mother is not positive, when they are substance or alcohol abusing. The data, as I said earlier, are unclear about whether employment and earnings are linked with maltreatment. Our study in 2009 found, in fact, that unemployment and income was not related to maltreatment risk. Actually, another study I should put up here, father's depression. We did another study that my colleague Shauna Lee published recently, and we found that father's depression is linked with father's maltreatment risk. And again, marriage is, although in the past, has been linked with, in a very crude way, correlationally. When you look at more multivariate kinds of analysis, marriage itself is not a protective factor.
It's so important some of these findings would be published, not for those who judge the article, but really for public use. So,
Trying to get out there, trying to get
no,
out there.
I don't know, I'm just saying. So I think when I'm working in a very clinic, never.
Oh, there's always a first time.
Yes,
Right? Good. Questions?
I want to thank you very much for this inspiring and innovative topic that you introduced to us. I really hope that we'll have a chance to host you one more time when we have some more results in our new offices of the Harouf Institute, the campus.
Good.
I want to thank everybody for coming today and looking forward to seeing you in our next Harouf seminar.